title of our program is Clinical Deterioration and Sepsis for Identification to Management. The Institute for Evidence-Based Care is pleased to offer you this webinar. Continuing education credits are available for doctors and nurses. Participants must remain for the entire session in order to claim the continuing education credits. Those involved in group viewing must complete the appropriate session evaluation found on the website www.meridianiebc.com and fax it to 732-481-8599 with your contact information so that we may return your certificate. A few highlights from the accreditation statements. For nursing, one nursing contact hour will be provided by the Meridian and May Center for Nursing and approved to provide continuing education nursing in nursing by the New Jersey State Nurses Association. Accreditation status does not imply endorsement by the Ann May Center or the American Nurses Credentialing Center for any commercial product services. Meridian is also accredited by the Medical Society of New Jersey to provide continuing medical education for physicians. This Meridian Health program is designated as a maximum of 1 A PRA Category 1 credit. Physicians claim only the credit commensurate with the extent of their participation in the activity. We identify that this program has no conflicts of interest for the presentation. We have no commercial support for the activity, and we overall consider the program free of bias as no speakers have declared any. This webinar will be available for viewing for at least 3 months for all Meridian employees and physicians via the webcast website, www.meridianiebc.com. It will be available online 24/7 throughout this time in YouTube and media play formats. Availability will begin approximately 3 weeks after the live broadcast of this offering today. Please encourage your colleagues to complete this webinar. This program is very comprehensive, and we do not have time for questions, but we will take them if you will email them to Kathleen Russell-Babin in the Institute for Evidence-Based Care, the address you see on the screen, and we will ensure you receive a prompt response from your experts today. Now, about speakers. We are very pleased to bring to you representatives from nursing, pharmacy, and medicine for today's presentation. Karen Emmett, MSN, CCRN, CNRN, is the Senior Manager for Nursing Services at Southern Ocean Medical Center. Previous to this role, she served in leadership and staff roles in ICU and rehab centers. She received a BSN from Keene University and her MSN from Walden University. She's a member of Meridian's Sepsis Steering Committee and has worked extensively on sepsis through a regional collaborative based on the Surviving Sepsis campaign. Michelle Cahoot, RMD, is a clinical pharmacist in critical care at Jersey Shore University Medical Center, a vital member of the multidisciplinary team. She also functions as adjunct faculty in the Ernest Mario School of Pharmacy at Rutgers, the State University of New Jersey. Michelle is a member of the System ICU Subcommittee of the Clinical Excellence Committee, the Chronic Obstructive Pulmonary Disease Team, the Trauma Committee, and many others in Meridian. She is a vital component of our committee input as the pharmacy point person for all work related to sepsis watershed. Dr. Erin Jacob is an emergency department physician in Meridian, working most often at Jersey Shore University Medical Center. She possesses a Master of Public Health from Johns Hopkins University and received her Doctor of Medicine from the Sackler School of Medicine in Tel Aviv, Israel. She completed both her emergency medicine residency and her fellowship in trauma and critical care at St. Luke's Hospital and Health Network in Bethlehem, Pennsylvania. She is a clinical instructor in emergency medicine for the UMDMJ Robert Wood Johnson Medical School. Dr. Jacob is the physician champion of our sepsis collaborative work with NJJ and an active member of the Sepsis Steering Committee. And Dr. Jacob will begin our presentation today. Thank you, Sharon.
Good afternoon. During the next 55 minutes, Michelle, Kim, and I will often be referencing the organizations. Surviving Sepsis campaign is a joint collaboration of the Society of Critical Care Medicine and the European Society of Intensive Care Medicine that is committed to reducing mortality from severe sepsis and septic shock worldwide. Initiated in 2002, the campaign has published 3 editions of evidence-based guidelines, implementation of a performance improvement program, and analysis and publication of data from more than 30,000 patient charts collected around the world. The 3rd edition of their guidelines was published in the February 2013 issues of Critical Care Medicine and Intensive Care Medicine. This bundle was revised in April 2015 by their executive committee based on the results of the Process, ARISE, and PRIME trials that were published in 2014 and 2015. The New Hospital Association Sepsis Collaborative consists of most, if not all, of the hospitals in the state of New Jersey. This collaborative began in early 2015 and has been collecting mortality data as well as rates of adherence to recommendations for management of severe sepsis and septic shock. Many hospitals have face-to-face interactions and discuss the practical aspects of implementing performance improvement initiatives. The Medicaid and Medicare services started collecting similar data in October of this year and have delineated specific guidelines that they will be reviewing and using for hospital reimbursement. As we talk about sepsis, it is very important to understand that there is a continuum of signs and symptoms with definitions and diagnostic indicators and mortality risks. While patients with SIRS may not even have an infection, patients with sepsis, think community-acquired pneumonia, strep pharyngitis, or pyelonephritis, are often managed by their primary care provider or discharged from the emergency department with outpatient management. Very clear literature that patients with severe sepsis and septic shock have a significant risk of dying. The early identification and management of patients with aggressive fluid resuscitation, broad-spectrum antibiotic coverage, removal of infection source, and other interventions improves their outcomes dramatically. The systemic inflammatory response syndrome was first described by Dr. William Nelson in 1983 and later adopted by American College of Chest Physicians and Society of Critical Care Medicine in the Sepsis Consensus Conference of 1992 to describe an inflammatory state affecting the whole body, frequently a response to the immune system to infection, but not necessarily so. SIRS actually has pro- and anti-inflammatory components related to an abnormal regulation of cytokines. SIRS bacteria are nonspecific and may be interpreted carefully within the clinical context. When it is due to an infection, it is considered sepsis. Non-infectious causes of SIRS includes trauma, burn, pancreatitis, adrenal insufficiency, blood loss, drug overdose, etc. The sepsis continuum is caused by an abnormal regulation of cytokines that cause both pro- and anti-inflammatory effects. This is when a pathogen stimulates the body's immune response. Inflammatory mediators stimulate the clotting pathway, causing the development of vascular microthrombi. Anti-inflammatory mediators are released and cause effects such as fever and capillary leak. At the end organ, dysfunction occurs due to decreased tissue perfusion. There are a myriad of cytokines involved with the pro- and anti-inflammatory cascades, including TNF-alpha, interleukins 1 and 6, and prostaglandins. Not the underlying infection, are responsible for the clinical presentation of the patient. I do want to spend a minute talking about ProCalcitonin. Calcitonin is an inflammatory marker similar to C-reactive protein, but is highly specific to a bacterial source. Calcitonin has proven helpful in differentiating between viral and bacterial infections when clinical symptoms of sepsis manifest themselves in the absence of a positive culture, and even to differentiate between bacterial infection and organ rejection status post-organ transplant. Accuracy regarding the presence or absence of bacterial infection is vital, as the overuse of antibiotics is the cause for the spread of antibiotic-resistant bacteria. Protein levels can be falsely elevated in Addisonian crisis, thyroid cancer, and in transplant patients receiving pan-T-cell antibody therapy. A procalcitonin value is less than 0.5 micrograms per liter. Levels elevate 3 to 6 hours after bacterial challenge, are greater than 1 to 2 in sepsis, but can increase to upwards of 10 to 100 micrograms per liter. This level reliably trends back downward with infection resolution. Procalcitonin has a half-life of 24 hours. As per my email conversation with Dr. Kathleen Casey of Infectious Diseases and Dr. Albert Reutman, Clinical Microbiology and Molecular Diagnostics yesterday, procalcitonin will more than likely be available for use at all Meridian hospitals by the first quarter of 2016. It cannot be used to initially identify cases, but to discontinue antibiotics in stabilized patients. Back to pro- and anti-inflammatory cytokines. The abnormal release of these various cytokines can lead to dysfunction in any or all end organs. Early recognition of encephalopathy, acute lung injury, shock liver, cardiomyopathy, acute kidney injury, and disseminated intravascular coagulation, or DIC, should lead to aggressive intervention that has been proven to improve patient outcomes, including decreased mortality. According to N.J. Hall et al. In a Center for Health Statistics debrief, from 2007 to 2009, over 2 million patients were admitted with a sepsis-related illness. 52% were diagnosed in the emergency department, 34% on the hospital wards, and 12% in the ICU. Sepsis is the 10th leading cause of death in the United States, and according to K. Reed et al. In an annual report from Health Grades, sepsis remains a leading cause of death in coronary care intensive care units with a mortality rate between 30 and 50%. Incidence and mortality rates from severe sepsis were comparable in 2001, before the last decade of aggressive interventions including TPA, cath lab intervention, and the involvement of the Surviving Sepsis campaign to further the early identification and aggressive management of our septic patients. The incidence of severe sepsis is increasing as it disproportionately affects the elderly and our population is aging. The U.S. healthcare system for sepsis and pneumonia grew twice as fast as the overall growth in hospital charges. Length of stay for a sepsis-related injury is markedly longer than for non-sepsis-related admissions. 9 months, Meridian Health System has been involved with the New Jersey Hospital Association's Sepsis Collaborative. Initial data collection shows that the mortality of hospitalized patients with severe sepsis or septic shock, excluding palliative care patients, for 2014. There is considerable variability amongst the Meridian Health System hospitals. The total average approximates the New Jersey state mortality rate of 23.71%. Hospital Association Collaborative and Meridian Health System have the goal of decreasing the mortality rate of non-palliative care, severe sepsis, and septic shock septic patients by 20% from 23.58% to 9% by June of 2016. The health system had 329 deaths in 2014, and this would have saved 66 lives. The Center for Medicaid and Medicare Services, known as CMS, has developed guidelines for the management of severe sepsis and septic shock patients. A section of charts discharge ICD-10 code for severe sepsis or septic shock will be viewed for specific data elements. Hospital reimbursement will be tied to guideline adherence. Since definitions for the sepsis continuum are slightly different than the literature definitions, I will read them briefly. CMS defines sepsis as having 2 of 4 of the SIRS criteria listed on this slide, plus a presumed or confirmed infection. At the bottom of the slide, you will see notation of other general and inflammatory variables that the Surviving Sepsis campaign also uses in its sepsis definition. CMS has no comment on the management of patients who have sepsis without severe sepsis or septic shock. According to CMS, patients with severe sepsis have sepsis, i.e. 2 of 4 of the SIRS criteria, plus presumed or confirmed infection, plus a single organ dysfunction. This organ dysfunction may include actual or relative hypotension, acute injury, elevated bilirubin, or signs of DIC, or lactic acid greater than 2. I have also listed for you the other parameters that the Surviving Sepsis campaign uses in its definition of severe sepsis. As by CMS, patients with septic shock have sepsis, i.e. 2 of 4 of the SIRS criteria, plus presumed or confirmed infection, plus tissue hypoperfusion. Tissue hypoperfusion is defined as a lactic acid greater than or equal to 4, or relative or actual hypotension that persists after crystalloid administration of 30 cc's per kilogram. I have also given you the definition used by the Surviving Sepsis campaign. I say that despite all the formally written definitions and guidelines that we are talking about, it's important to be a smart and thinking practitioner when evaluating your patient. While I want everyone to always consider the definition of the sepsis continuum and thoroughly screen for it, patients should be directed by what you think is best for the patient. But your consultants and billers and coders can't read our minds. If considered and are discarding the issue of infection, please document this in your notes. The Surviving Sepsis campaign and the New Jersey Hospital Association Sepsis Collaborative recommend routine screening of potentially infected, seriously ill patients for severe sepsis to include the early identification of sepsis and allow implementation of early sepsis therapy. To that end, Meridian Health System developed and placed on dashboard under evidence-based guidelines a sepsis criteria reference. This page is currently being updated to include the recently released CMS recommendations. Screening will be taking place during triage of all emergency department patients and on all rapid responses. As we encourage all health system members to become familiar with and think about these screening criteria when interacting with patients. Patient dynamic and may develop a new infection or deteriorate from an already identified one at any time. For CMS defined severe sepsis requires, within 3 hours of meeting criteria, a lactic acid level. This is a gray top tube on ice, bacterial draw, or venous with no tourniquet, please. Blood pressures before antibiotic administration and administration of broad-spectrum antibiotics. Patients with CMS-defined septic shock, CMS requires, within 3 hours of meeting criteria, all of these actions, plus administration of crystalloid IV fluids in the amount of 30 cc's per kilogram. As system policy indicates, this fluid may be given as a bolus, off pump, with a bag. For CMS-defined septic shock, CMS requires, in the 3 to 6 hour window after meeting criteria, the institution of vasopressors when needed, and a reassessment of wound status and tissue perfusion. In addition, if the patient's first lactic acid was greater or equal to 4, the patient needs a repeat lactic acid level. The sepsis campaign used to require the placement of a central venous catheter and central venous pressure measurements with targeted pressure goals in management of septic shock. With the publication of the Process, Arise, and Promise studies in 2014 and 2015 that do not show superiority of these interventions in septic shock patients who have received time antibiotics and fluid resuscitation compared with controls, the sepsis campaign revised its bundle to allow the elements listed in column A to substitute for the elements in column B. C defines an assessment of repeat volume status and tissue perfusion as all of column A, meaning a documented exam, including vital signs, cardiopulmonary exam, capillary refill status, peripheral exam, and a skin exam by a licensed independent practitioner, or 4 of column B, C measurements, oxygen measurements, bedside cardiovascular ultrasound, or response to either a passive leg raise or fluid challenge. This current Meridian Health order set for initial suspected severe sepsis and septic shock, as it is found on dashboard under the link for evidence-based guidelines. This is a process of being updated to better reflect CMS requirements. It includes initial testing, initial dosing of broad-spectrum antibiotics as recommended by the Infection Control Committee based on our antibiogram, fluid resuscitation, and vasopressor recommendations. While the Center for Medicaid and Medicare Services has divided its interventions into 3- and 6-hour bundles, we asked our order set request as first hour because we know based on the literature that earlier intervention improves outcomes. There are a whole host of other recommendations by the Surviving Sepsis campaign for the management of severe sepsis and septic shock. Patients required these conditions should be in an intensive care unit, and I will defer discussion of these interventions for now. If you want to read more about Surviving Sepsis campaign recommendations, there is a 61-page summary article and numerous other documents available for free online. I'm going to pass this discussion on to Michelle Cahoot, who will be discussing the intricacies of the antibiotics, vasopressors, and supporting medications used in severe sepsis and septic shock.
Dr. Jacob. I'm going to begin my portion of the webinar with an explanation of the grading system that is used to indicate the level of evidence for the various recommendations. We'll then review the role of antimicrobials, vasopressors, inotropes, corticosteroids in the management of severe sepsis and septic shock. The information that I will be presenting is primarily based on the Surviving Sepsis Campaign guidelines by et al., published in 2013 as referenced on this slide. Through the slides, you will see a grade level listed for many of the drug therapy recommendations to indicate the strength and quality of the underlying evidence. The grading scheme classifies recommendations as strong, grade 1, weak, grade 2, according to the balance between benefits, risks, risk, and cost. The system further classifies the quality of evidence by grade A, grade B, low, grade C, and there can even be a grade D, which is even lower. This is according to factors that include the risk of bias, consistent results, and the directness of the evidence. The grades in my part of the webinar are based, again, on the Surviving Sepsis guidelines. Start with the antimicrobial therapy. The sepsis guidelines indicate that the initial empiric antimicrobials need to include one or more drugs with activity against the likely pathogens, including Pseudomonas and Acinetobacter. It's been repeatedly shown that empiric therapy that does not cover these pathogens that are later found to be the cause of infection is associated with significantly worse outcomes. Antimicrobials must target and and achieve adequate penetration into the tissues presumed to be the source of the sepsis. There is no evidence of the value of empiric combination antibiotics to assure that the infecting microorganism is treated. This empiric antibiotics in our Meridian sepsis protocol take all of these factors into account. Our protocol was developed with our Meridian infectious diseases teams based on our Meridian-specific antibiograms and resistance patterns, as well as the most likely microorganisms in our patient population. While sepsis requires antibiotics to be administered within 3 hours, literature shows benefit of early intervention with antibiotic administration within 1 hour. As we look for the best patient outcomes, Meridian's protocol similarly follows the Surviving Sepsis campaign, which necessitates antimicrobial administration within 1 hour. The earlier we can get the antibiotics on board, the better. Here you can see Meridian's standardized protocol for the antibiotics. It includes imipenem, vancomycin, as well as gentamicin. This can be utilized in the emergency department, the ICU, or on the floor. And as you can see, it provides for the first dose only of antibiotics. Further orders must be ordered by the admitting attending physician based on the source of infection, cultures, and other clinical patient-specific data. We have experienced a national drug shortage of imipenem in recent months. Should it become necessary, we will temporarily replace imipenem with ertapenem in our septic patients. Note that ertapenem does not provide pseudomonal coverage, so it is important that the gentamicin is given along with the vancomycin. If a patient has a severe IgE-mediated hypersensitivity allergic reaction to penicillin, namely rash, urticaria, hypotension, and/or edema, you see that Cipro replaces the imipenem in the protocol. There is a potential risk of cross-reactivity using imipenem in a patient with penicillin allergy. The vancomycin and gentamicin administration and dosing remain the same. Additionally, if a pulmonary source is suspected as the origin of the infection, azithromycin should be administered in addition to the triple antibiotic therapy that I just discussed. If a patient is also currently on amiodarone, doxycycline should be ordered instead of azithromycin, as there is category X drug interaction, which is the highest, most severe level of drug interaction, due to the additive risk of QTC prolongation with amiodarone and azithromycin. To ensure that the antimicrobials get aboard as quickly as possible, it is Meridian's policy that more than one antibiotic is administered concurrently in a septic patient. The risk of hypersensitivity reaction to the specific antibiotics within our protocol is minimal, and the benefits of early administration far outweigh the risk of any reaction. As we mentioned, the Surviving Sepsis campaign indicates that it is imperative for patients to receive their antibiotic regimen within 1 hour of progression of sepsis or septic shock. In the presence of septic shock, each hour delay is associated with an increase in mortality. Thus, it is necessary for the antibiotics to be given concurrently. Administering the antibiotics with the shortest infusion times first will also help get the antibiotics on board faster. When administering the antibiotics or medications together via Y site, be sure to check IV compatibility first to ensure the IVs can safely be administered together and not form any type of a precipitate. You can ask the pharmacist or check IV compatibility on Lexicomp online or any other reliable reference. Specific to our protocol, note that vancomycin and imipenem are not compatible in a Y site. Patients need to be continually reassessed, and the antimicrobial therapy should be de-escalated and streamlined as soon as possible. It helps to reduce the development of antimicrobial resistance, reduces exposure and toxicity, rates of C. diff, and also reduces the associated drug therapy costs. I do want to mention that if a viral origin becomes suspected, that appropriate antiviral therapy gets started as soon as possible. we need to target and modify therapies to best treat the source of infection. Shift gears to vasopressor therapy. After adequate fluid resuscitation, which you'll recall is 30 milliliters per kilogram of crystalloid, vasopressors may be initiated to attain a MAP of 65. The choice of vasopressor, the surviving sepsis guidelines recommend norepinephrine as the drug of choice. Grade 1B recommendation, which is a strong recommendation. Norepinephrine is a catecholamine that causes significant vasoconstriction, thereby increasing blood pressure and coronary blood flow. The main adverse effect to be aware of with norepinephrine is the risk of arrhythmias. Next comes epinephrine. It is similar to norepinephrine and causes vasoconstriction and may increase cardiac output. However, it is associated with more arrhythmias and other cardiac adverse effects such as angina, tachycardia, and ventricular ectopy. The sepsis guidelines suggest that epinephrine can be added to norepinephrine or even substituted in place of norepinephrine. This is a lower level of evidence, however. As you can see, it is a grade 2B recommendation. Thus, I strongly recommend continuing to use norepinephrine as your first-line vasopressor. The vasopressor that comes into play is vasopressin. It's a vasopressor that works by a different mechanism and can affect even in patients with norepinephrine or epinephrine-resistant vasodilatory shock. It's shown that in acute shock states, vasopressin levels initially increase and then decrease in prolonged shock, leading to a relative deficiency of vasopressin. This deficiency is thought to contribute to the hypotension of shock. Vasopressin is dosed at 0.03 units per minute and added to norepinephrine to improve organ perfusion, increase MAP, and improve blood pressure. Current evidence does not support the use of vasopressin as a replacement for norepinephrine as a first-line agent or as monotherapy. Doses greater than 0.04 units per minute are reserved for salvage therapy in patients who have not adequately responded to fluids and other vasopressors. Doses over 0.04 units per minute increase the risk of cardiac ischemia and cardiac arrest. Dopamine. Dopamine is not recommended in septic shock due to the risk of tachyarrhythmias and other cardiac adverse effects. There is also data from 5 randomized trials which included nearly 2,000 patients with septic shock comparing norepinephrine to dopamine, which did not support the routine use of dopamine in the management of septic shock. Norepinephrine was consistently found to be superior. Lastly, low-dose dopamine should not be used for renal protection. It has not been proven to be effective, and this is the highest level of evidence, a grade 1A. There's limited literature on the use of phenylephrine in septic shock patients, thus it is not recommended. Phenylephrine is also associated with ischemia, low cardiac output, and severe peripheral vasoconstriction and reflex bradycardia. Since there is one small trial of phenylephrine in septic shock, and there are other agents available, the sepsis experts only suggest it as a potential consideration in highly selected patients who need alternate treatment to norepinephrine or salvage therapy. This is a 1C, indicating low to very low quality evidence. As an inotrope, and may be initiated for patients with decompensation who have low cardiac output or continued tissue hypoperfusion despite adequate intravascular volume and adequate MAP. Also a grade 1C, low to very low quality evidence. Be limited to 20 mics per kilo per minute, as higher doses are associated with an increased risk of arrhythmias. I'm going to wrap up my portion of the webinar discussing the role of corticosteroids. Before the drug therapy itself, it's important to note that an ACTH stimulation test should not be utilized in an attempt to identify which septic shock patients should receive a corticosteroid. The European Corticus trial from 2008 confirmed that an early ACTH test was not able to predict responsiveness to a steroid. Patients who are potential candidates for corticosteroids are septic shock patients who are unable to be stabilized despite adequate volume and vasopressors. If to initiate a corticosteroid in this setting, high cortisone IV is the drug of choice. The dose is 200 milligrams IV daily. This can be administered as 50 milligrams IV every 6 hours. That the use of hydrocortisone is a weak recommendation with very low quality evidence. Alternatively, a continuous infusion of hydrocortisone at the same daily dose of 200 milligrams may be used. This equates to about 8.3 milligrams per hour. Some have suggested that the hyperglycemia side effect that occurs after steroid boluses is avoided when a continuous infusion is used. There is no evidence that this has an impact on the patient's outcome. Therefore, this is also a weak suggestion, a grade 2D. Lastly, there can be a significant rebound in hemodynamics following abrupt discontinuation of a hydrocortisone infusion. To avoid this, it is recommended to taper off the hydrocortisone infusion over several days. Again, this is a weak recommendation with low to very low quality of evidence. I'm going to turn over the webinar to Kim to discuss standard call parameters, early warning score, and the use of rapid response.
Thank you. The Surviving Sepsis Campaign and the New Jersey Hospital Association both recommend early identification of sepsis patients. The identification of sepsis patients should not only be limited to patients in critical care areas, but those patients in med-surg and telemetry. By early deterioration in sepsis patients, the lower his or her mortality rate risk is, allows the practitioner to stop the sepsis cascade sooner. But while they identify sepsis patients who are deteriorating, they represent only one segment of our patient population. Why not try to identify a patient prior to the significant change in his condition? At Meridian Health, we are adopting the standard call parameters, the early warning score. We will be utilizing the expertise of our rapid response teams at more defined circumstances, increase sepsis screening, and as always, we will continue our great collaboration between physician and nurses. Let's start by discussing the standard call parameters. The standard call parameters are the predetermined lower and upper limits for signs considered normal, including oral and rectal temperature, systolic blood pressure, diastolic blood pressure, heart rate, respiratory rate, pulse ox, and mental status. So when the vital signs fall outside this range and there is no PRN or as-needed medication or treatment to address the fallout, a call will be placed to the licensed independent practitioner. The vital sign will be reported using the SBAR format. When you think of standard call parameters, please keep the policy points in mind. Remember, hospitalized adult patients who are located in non-critical care areas or under observation status will have the standard call parameters in place, unless overriding more frequent orders. Do not call a licensed independent practitioner. You would not immediately call when there is a PRN order to address the issue. You would administer the treatment and reassess the effect in an hour. If treatment was ineffective, you would call the IP for further orders. How often are we going to be doing vital signs? Vital signs are going to be completed every 4 hours for 24 hours after admission, every 4 hours for 24 hours after transfer to the intensive care unit, every hours for 2 hours post-operatively, or where a nurse or a practitioner's judgment calls for a repeat in the vital signs, and for any or concern about clinical deterioration. A quick Mr. Allen. He was dizziness and syncope, heart rate, who was admitted for dizziness and syncope. While he presents with an elevated heart rate of 160 with his known rhythm of AFib. After you determine that Mr. Allen is stable, it is time to ask yourself, do I have a PRN order to address this? I don't. I do. You're going to call the licensed independent practitioner. Good job. Scenario with Mrs. Smith, recently admitted for exacerbation of COPD with multiple comorbidities. Her respiratory rate is 36. You're going to ask yourself, well, you're going to ask yourself, is she stable? Of course she's stable. She's got a respiratory rate of 36. You're going to rest after you give the PRN treatment. If the treatment works after that hour, then you're done. If not, you're going to call the LIP and ask for further treatment. These are the standard call parameters. According to the Institute of Healthcare Improvement, when rapid responses were first initiated, the main indicators for the teams to be called would be a normal single vital sign or a practitioner's gut feeling. For example, a significant change in blood pressure or the color or any one specific vital sign would call for the bedside evaluation. So call a rapid response that would refer a critical care nurse and a respiratory therapist to the bedside. States that rapid response teams reported that approximately 40% of calls were initiated due to someone identifying that something just wasn't right with their patient. This begs the question, how do we standardize, quantify, and become proactive in identifying deterioration in all patients before a single value is grossly abnormal, or only by relying on intuition? The answer to that question is the early warning score. Warning score is a numerical value obtained from a calculation based on weighted vital signs consisting of heart rate, respiratory rate, oxygen saturation, temperature, which are rectal or orally. Do not do ancillary temperatures, please. Oxygen saturation, temperature, blood pressure, inspired oxygen, and alertness. The early warning score reflects degrees of clinical deterioration, which unhampered may result in mortality. The early warning score has been utilized around the country and in other areas of the world. Evidence-based, it provides a quantification of a patient's condition to demonstrate deterioration that will direct specific actions by the bedside registered nurse that will correlate to the patient's score. As stated by the table, the early warning score, the higher the risk of mortality. To identify a patient with an upward trending early warning score at 5 allows for the physician and team to provide proactive treatment, as opposed to waiting for a single value change or a gut feeling to initiate action. As you can see, the slide once past 5, there is a significant uptick in mortality. The early warning score. The early warning score reflects clinical deterioration. It is predictive of mortality as levels increase and addresses a composite of vital sign measures foretelling of a patient's condition than the single value. The values are assigned to the value per the table. As the score increases, so does the level of escalation. Scores fall between 0 and 4, stable. Between 7, calls for increased vigilance, with vigilance every 4 hours. High awareness of patient's condition by both the nurse and physician. Finally, a score of 8 and above calls for immediate action and will trigger a rapid response. Nurses with guiding escalation of treatment for an upward trending early warning score. We have escalation guidelines. Guidelines are to advance the treatment timeline and therefore to decrease the risk of death for all inpatients. I'm not going to read the entire table, but it is important that for the nurses to note these escalation guidelines are important to be followed, and once an escalating score is calculated, you must call the practitioner. So how does this work? There's going to be a new chapter in Storian where the guidelines will be pulled into. Will then calculate the early warning score. Then we'll need to acknowledge the score. Escalation guidelines will also be located as a link in the early warning score chapter for your convenience. Remember, at any point, you have the option of calling a rapid response. If your patient has had a negative change in condition that really warrants immediate help at the bedside, regardless of your early warning score, you have the ability to always call a rapid response. The goal is to increase awareness of a worsening patient condition, not the nurse's opportunity. Early warning score and standard call parameters are tools that nurses now have and will use them with their critical thinking and patient advocacy. By no means are these tools meant to limit your ability to best care for your patients. The protocol. The early warning score will be completed every 4 hours for the first 24 hours. Full set of vital signs are entered, the score should be calculated and acknowledged. If the score is 5 or above, the vital signs remain every 4 hours. If the 0 to 4 for 24 hours, the vital signs will then move to the meridian routine of hours at 8, 4, and 12. Remember, judgment and concern for your patient's condition and the patient's needs will dictate if you need to do an extra set of vital signs at any time. So how does this relate to sepsis? Both call parameters and early warning scores help nurses to identify early signs of sepsis and object to trigger an escalated medical response. These parameter scores are not limited to sepsis and help nurses save lives in many conditions. In addition, all rapid responses will have a sepsis screen complete with an early warning score of 8 and will automatically trigger rapid response. So we're going to do a quick case study. We're going to Mr. Murphy, a 44-year-old man who came into the emergency department with chest pain. His vital signs were 148/72, with 88, respirations 24, his ox was 96, he was at that point on 2 liters via cannula, and his oral temperature was 100.4. His mental status is alert and oriented, and the screening was complete in the emergency department and was negative. The screenings will be completed on every patient coming through the Meridian Health emergency department. How he does as he moves along with his stay. So he's stable. His early warning score is 2. He's removed his oxygen at this point because he feels so good. He's ventured up to the floor, and we're going to see how he's doing. At Mr. Murphy's vital signs as a snapshot. They don't look alarming. The full value snapshot approach is what happens today, especially if you're transferring care from practitioner to practitioner, bedside shift report, or transferring from one unit to another. Let's really look at these vital signs in another way. Let's look at them with the early warning score and see if that agrees. Mr. Early warning score is 7. That's alarming. This warning score indicates that we need to escalate care. You're going to give your medications based on call parameters, and now you're going to place your call to the physician or licensed independent practitioner with their recommendations for a bedside evaluation. Time is of the essence. Notify the licensed independent practitioner, and if they don't call, feel free to escalate. Take a closer look at what these two different scores mean. The blue arrow indicates your first early warning score on admission. He's a 2, stable. Your second early warning score is the red arrow, which is a 7, and you can see how the mortality risk significantly increases. If you look at his vital signs as a snapshot in relation to the initial early warning score, you recognize that this is an alarming trend. Mr. Vital signs not be addressed in the same manner as when you attach the early warning score to them. To better indicate Mr. Murphy's condition, the practitioner is to use the SBAR, per Meridian Handoff Communication Policy. And everyone should be familiar with SBAR. If you're not, here's just a reminder slide. Is your situation, B is your background, A is assessment, and R is your recommendation. When you're using SBAR, you should provide a consistent framework for the communication of important patient information between team members when taking responsibility of a patient from shift to shift, unit to unit, or from one caregiver to another. And this is our standard, and it's going to provide the best way to get your message across. See how Mr. Murphy is doing. Oh boy. So, Mr. Murphy is continuing to deteriorate. The current events have not turned him around. What do vital signs look like in relation to mortality? See then how to calculate an early warning score. His warning score now is 11. So his pressure still isn't alarming, 130/88. His pulse still isn't alarming at 92. His respirations are slightly concerning in our current practice today at 34. And of course, we're concerned with his temp of 2.4 and his pulse ox at 88. He has an unchanged mental status. If you walk into his room, he's talking to you. He's alert. Look at the early warning score. He's a rapid response. So our call for the early warning score over 8. And we change a little bit. For anyone over 8, even if they're looking stable, you need to call rapid response. The rapid response team attending notified. So the rapid response team will monitor vital signs every 15 minutes. Your sepsis screen will be completed at the bed by the rapid response response team. Supportive treatment. The patient remains an early warning score of 8 or above and is unstable. You have to prepare the patient for transfer to higher level care. The patient stabilizes at 8 or less. Electronic health record and order for increased vital signs monitoring every 4 hours. Initiate the chain of command as needed if lack of medical response. Remember, the early warning score and standard call parameters are tools to sepsis, but they're tools to fight deterioration in any condition. I think you can note the fine difference from the first score to the second score, and the mortality risk from the first score to the second score, and the significance of early treatment and early intervention. Wrapped up with Dr. Jacob, and just remember, these again are the tools in the fight against sepsis. It will help all of our patients get the best treatment in a timely manner from the best team.
Thank everyone for their attention to our webinar today. During this hour, I have discussed the pathophysiology and impact of severe sepsis and septic shock and recommendations for the screening and initial management of our severely ill patients, the 3- and 6-hour bundles as per the Surviving Sepsis campaign and the Center for Medicaid and Medicare Services. Michelle has reviewed the pharmacologic management of severe sepsis and septic shock in terms of initial antibiotics, vasopressors, inotropes, and steroids, and reviewed the Meridian Health System's new standard call parameter early warning score policies.
Dr. Jacob, Dr. Cahoot, and Ms. Clement for a wonderful presentation. I'd like to emphasize a couple of points that this was certainly not our only vehicle for communicating this information. There are a variety of vehicles out there. There are health modules for nurses, posters and newsletters carrying CME for physicians. We created a pocket card, early warning score and standard call parameters, so that at a glance you can see that early warning score of 0-4, you're in a good zone. 5 to 7, it's time to become vigilant, and 8 and above, you're calling the rapid response team. We're going to build into the rapid response team documentation the sepsis screening criteria, so at a glance as they move to the bedside. These are but a few of the mechanisms that the system is working on to improve care of our patients and prevent clinical deterioration. Thank you all for joining us. A reminder, participants must complete the appropriate session evaluation form found on the website www.meridianibc.com and fax it to 732-481-8599 with your contact information so we may return your certificate if you are not in a group setting. This is our program for today. The Institute for Evidence-Based Care is pleased to provide you this webinar, which will be posted to the intranet and the website